Hey everyone, it's Hunter Hicks. Today we'll look at some COPD causes. Hey everyone, today we're going to look at COPD and asthma. We're going to look at causes and treatment. So first, COPD. Now COPD obviously is an umbrella term, which you probably know by now. Now, COPD is made up of chronic bronchitis and emphysema. First, chronic bronchitis. Now remember, bronchitis, inflammation of the large airways or the bronchi. Now this can be caused by a lot of different things. People that normally get bronchitis can just be viral infections of the upper airway and things like that. However, we see here in chronic bronchitis with COPD, the toxic exposure of smoke constantly to the bronchi creates this inflammatory reaction. Now, chronic bronchitis is just that. It's bronchitis, but they have it chronically, so it's this chronic inflammation all the time of the bronchi. What happens here is we get both edema, we get the goblet cells, which we know release mucus. They get larger and increase more mucus. Now, between the edema, everything going on with our goblet cells, and actually a little bit of decrease in our pseudoepithelial cells, which we know bring bacteria up to the oral pharynx, we get a lot smaller diameter for air to flow in and out. For that reason, we see these patients' issues getting air out, meaning air can usually get in pretty well, but we can't get air out. However, during exacerbations or even during really bad COPD, we have decreased air movement throughout these tubes in general. By tubes, I mean bronchi. So we start to see a degree of hypoxemia. Now, emphysema is a little bit different. Emphysema is going to look more at the bronchioles and the alveoli, but it can also include the bronchi. Now, there's different types of emphysema, but really the one we're going to talk about today is the one involved in COPD. By that, I mean there are people that are healthy that might actually lack an enzyme, which puts them at higher risk for emphysema. But here we're going to talk about this, the smoke-induced emphysema. So what happens here, again, we have this exposure of smoke. And what happens, we get this inflammatory reaction. Well, we get a lot of inflammatory mediators, but we also get things like protease. Protease is an enzyme that's going to break down both our collagen and our elastin. First, let's talk about elastin. Elastin is obviously in the alveoli and throughout the lungs, and it helps those lungs kind of snap shut, push air back out. And the alveoli, if you think about it like a balloon with a rubber band, air comes in nice and easy. But it doesn't increase it too much because we have that elastin, that rubber band, that eventually is going to kind of get stuck right there. Then it snaps back and pushes the air back out. When we lose that elastin, two things happen. One, the alveoli can get way bigger because now there's no rubber band around it, so it can get very, very large. And we also lose that nice snap back ability to push air back out. So, as the air comes in, alveoli says, yes, I'll take all that air, but now I'm stuck kind of like this big balloon and I can't push air back out that well. So we start to get this hyperinflation of the alveoli and the lungs. The other thing is collagen. Collagen we find throughout the airway walls or our bronchial walls. And what happens is when air gets pushed back out, naturally those walls want to close. Well, the collagen is nice because it kind of pulls those walls nice and open. So it holds them while air is going out. It's like go, 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 go. So it leaves them open. Well, protease, one of the enzymes we know during this inflammatory reaction, kills off that collagen. Therefore, when air goes out, push. So, not only are our alveoli getting bigger because no elastin, but now we're collapsing that small airway. Therefore, the air comes in and then it can't get back out. So we have all this air just kind of sitting there. Now, last but not least, the alveoli themselves have septa, or walls around them. And around that are all this vasculature, right? All these pulmonary arteries and pulmonary veins. We like all of them around that because that increases the surface area of the alveoli for gas exchange. CO2 going off, oxygen coming in. However, in emphysema, we start to break those walls down. So the alveoli start to form one big kind of alveoli. This might look good, but however, now we just have one alveoli with blood around it versus we had like 20 before all in this little area with blood around them. So we had a ton of areas for gas exchange to occur. Now they're all together and we only have really one area. So obviously these patients have issues with ventilation, meaning hypercarbia, increased CO2, but eventually we'll totally see them have issues with hypoxemia. Now, as far as them presenting to us in clinic, some of the symptoms we can see, and one of the diagnostic factors is they're going to have a productive cough for 3 months out of the year for at least 2 years. And what that productive cough, meaning productive, is we're coughing up the mucus from those goblet cells. Now, obviously, we can see this way worse when they have exacerbations, but that's usually what we're seeing here. They can either present as pink puffer, blue bloater, or both. Pink puffer is more in emphysema, pink meaning they usually don't have issues with hypoxemia until later. Puffer, meaning that they push the air out. If they puff their lips and push the air out slower, they prevent that collapse of those airways that we looked at earlier. Blue bloater is in our chronic or our bronchitis patients because they usually have a degree of hypoxemia earlier. Obviously, everything in the way of that bronchi makes it difficult to move air. If we're not moving tidal volume in the lungs, we're getting less exchange of gas. Now, some other things we can see is generally their appearance are usually skinny. The reason for this is the increased amount of work it takes for them to breathe and do things every day, and it might just be hard for them to eat. Now, obviously, they can have a degree of obesity or metabolic syndrome if they have other chronic diseases, but this might be what you see with them. Another thing you might see is they might actually bend over and put their arms, extend them. That might actually increase the diameter and help them breathe better when they're having these exacerbations. These patients are at high risk for frequent infections, some we see very often with them. It's actually also something we're going to look at later to see how well controlled their COPD is. The reason for the frequent infections is, for one, chronic inflammation is going to kill off a lot of our protective mechanisms. One of them is that cilia that moves bacteria up the airway and elicits a cough reflex, so we push that bacteria back out. We start to lose this, and the bacteria is able to sit down in our airways and grow and cause issues. The other thing is there's so much in the way. So if we get a nice bacteria down there and it gets stuck, it's obviously going to create issues. Now, two things come about this. We're already in a chronic inflammatory state, and we're barely moving air as it is. As you can imagine, with any kind of infection, that inflammatory reaction now doubles itself, and we really, really have issues moving air in and out. These patients present, and they can be awfully very sick. Why it's very important for these patients to make sure they're trying to stay as healthy as they can and getting their vaccinations against pneumonia, like pneumococcal for strep and influenza. Diagnosis, sometimes a chest x-ray can help. What we'll see is that they have a flattened diaphragm. What you remember is the diaphragm is a dome. Well, when there's a bunch of air in the lungs, it's pushing that dome down. So we'll see more of a flat diaphragm on x-ray. Their diameter of their chest, AP, will actually be larger. The reason for that is, again, all the air they're holding on to. A common thing we see is the FEV1 to FVC ratio. Now, what this is, forced vital capacity, or FVC, is the amount of air the patient's able to breathe out totally, usually around 5 liters. The FEV1 is that same concept, but in the first second of the breath. Usually when we do the ratio between these two, it's usually two pretty high numbers. Above 80% is pretty normal. Now, when we start getting less than 70%, meaning we are able to breathe out less air during that 1 second and totally, we start to see FEV1 FVC ratio less than 70%, which helps our diagnosis. As far as treatment, we're going to cover these in both COPD and asthma later. But some of the things are anticholinergics or antimuscarinics, SABAs or short-acting beta agonists, usually for PRN and exacerbations, long-acting beta agonists, and steroids for exacerbations. Now, asthma is a little bit different. Asthma can happen at any age, but it's going to be worse in our kiddos. The reason for that is we know the diameter of the bronchioles and bronchi are already smaller, meaning we already have less air moving. Anything to get in the way of that bronchiole is going to make a lot bigger symptoms in our patients. That's why we always worry about respiratory issues in kids. They naturally will just look worse and get sicker because that diameter is smaller. Now, kids usually young kids can get this. They can even outgrow it sometimes. And that's just the genotype they have. Now, we can see asthma actually present in adults too that possibly didn't have it prior as a kid. Now, what happens here is we usually have an antigen, and that could be whatever the child genes deno or say is going to be something that causes a reaction. So it could be anything. What happens here is we get this exposure of the antigen, and we have a huge release in the inflammatory cells. A lot of our white blood cells, especially those T helper cells that we know create a lot more white blood cells. In general, what we see here is an inflammatory reaction. So we get edema and then an increased amount of mucus to try and capture that bacteria and get it out of the body. We also see a lot of bronchoconstriction, which is normally something our lungs do to try and prevent bacteria from getting down into lower airways. All of this going on creates an issue with airway movement in the lungs, obviously creating the symptoms we see. Now, causes, this is very interesting. A lot of this can be familial, meaning the child is either born with it and they have a certain genotype. That genotype then is our phenotype, which is phenotype being what we see. So a lot of different genotypes or phenotype are like type 1 hypersensitivity. Type 1 hypersensitivity or allergic asthma is one of the most common, meaning the child usually already has allergies, other things, but the asthma itself is caused by an allergy to whatever substance or antigen it might be. Usually in this, we see a lot of IgE-related antibodies, and then our eosinophilic asthma, we call it sometimes. This asthma is usually more responsive to steroids, whereas some of the other ones aren't, such as neutrophilic. Neutrophilic asthma, where we see a high degree of neutrophils when we look at their blood, sometimes can be more severe. The exacerbations can be a lot worse, and they're sometimes refractory or not able to be treated with steroids. Exercise-induced, something we can see. This sometimes happens right away during the exercise, or after. Aspirin sensitivity is another one. So as you can see, there's a lot of different kinds of asthma. But in general, the idea here is really the same with the physiology. But the interesting thing is some patients just naturally are going to get a lot sicker, which is why it's always interesting to talk to your patient. Some of them may have had intubation or a tube down their airway, whereas others may have never had that at all. Well, that should be a red alert to you, because you could be dealing with a genotype or phenotype that's much more extreme, like neutrophilic, compared to our patient with eosinophilic. In general, these are patients you do not want to mess around with, as they can crash very fast. Symptoms are pretty obvious. We can see a cough, shortness of breath, and that very famous wheeze. The wheeze, caused by turbulent flow of air trying to get out of the body or into the body, is caused by the bronchoconstriction and the edema we see. Now, we know the wheeze we can see early on. However, you need to be very careful. If you have a very sick child in the emergency department and that wheeze started, now it's gone, and you haven't started treatment, that's what we call silent chest, meaning the obstruction is so bad we are moving less air. Remember, wheeze is caused by turbulent flow. Well, if it's so small in there, there is no flow. That air is barely moving. You won't hear anything at all. Outside of this, patients are usually very tachypnic at first, meaning our PCO2 or total CO2 in the blood is going to be low. Well, you just see a respiratory alkalosis. However, as they tire and as the obstruction gets worse and we're moving less air, that CO2 will rise, and respiratory acidosis is a good indicator for respiratory failure or respiratory arrest is about to occur. These are all good things you want to be checking out. Lastly, what I'll say is that the obstruction gets worse, that diameter is going to get larger. Well, a lot of their muscle use that they use to breathe, these kiddos, starts to be impaired. As the air gets in, it actually is kind of making those muscles not work as well. So not only are they getting tired, but this really big diameter is making it harder for them, and those muscles aren't working as well anymore, as you'll see the respiratory acidosis set in. Treatment and diagnosis, again, we're going to cover all of these, but it can a lot of times be missed. We know a lot of things might actually look like asthma, right? Like bronchiolitis caused by RSV. They'll have a degree of wheezing too. Well, an asthma child might have an upper respiratory infection that causes the exacerbation, which also looks like bronchiolitis. However, chest x-ray can be helpful here. History of allergies, or just in general, any history of an asthma attack might be able to help you out here. Obviously, chest x-ray and signs and symptoms of infection might be more likely to see with bronchiolitis, and maybe not so much with asthma. In general, really look at these kids because this often gets missed. Now, as far as treatment, a lot of the medications we give to these patients are going to be inhaled. We're going to look at the different kinds of ways to inhale medications. First is an MDI, or a meter dose inhaler, commonly just called inhaler. Now, the issue with an inhaler is the patient has to be breathing before they dispense the medication, so it gets into the lungs. This causes a degree of incoordination, and which is why a lot of times up to 80% of that medication sits in the oral pharynx, meaning just here in the mouth and never gets down to the lungs. For that reason, we can use things called spacers, which attach to the actual nebulizer itself. Sometimes these are one-way valves, meaning when the patient breathes in, the medication puffs with it, which makes it a lot easier, and we help guarantee that medications get down in the lungs. Now, we'll talk about this, but a lot of times, some of the most common things we'll see because of these are going to be hoarseness of the voice and oral fungal infections, which is why it's really important with any of these to always rinse after. Now, another one is the DPI, the dry powdered inhaler. This one's usually a little bit easier. Why? You just put it on your mouth, breathe in, and it snaps, meaning when it feels that you're causing that negative pressure, it dispenses the medication into the body. Last but not least is the nebulizer. This is common to see it at home and also common to see in the hospital when a patient has an exacerbation. It takes the particles and actually puts them in a very small mist, which helps allow it to get down into the lungs. Now, as far as medications, glucocorticoids like fluticasone and budesonide are going to be helpful here. Now, they're a little bit different with the two diseases. For asthma, we're going to see this more prophylactically, meaning as the patient gets worse on more of a step 2, step 3, they might have a short-acting beta agonist and also an inhaled steroid that they are taking every single day. However, more common in COPD to actually only be for exacerbations when they come in sick. That's not always, but more commonly, this is how we see it at first. Now, glucocorticoids are great because they're going to decrease prostaglandin and histamine, two of the main things we see in this exacerbation that cause the increased permeability, so fluids getting in the lungs, increased edema, everything that we're seeing here. Now, some of the routes can be inhaled, most common, or if it's more severe, we can see PO format, so they're just taking a pill. Now, the PO is going to put them more at risk for adverse reactions, whereas the inhaled, because inhaled usually is absorbed more in the lungs, so you have less systemic effects, whereas if you're taking the medication, systemic effects are going to be greater. Some of the side effects that we could talk about is going to be this oral fungal infection and the hoarse voice. Now, the reason for that is because all that medication is kind of irritating sometimes the larynx and that vocal cord area and the oropharynx. Some things we can do are antifungals or just have them make sure they're washing it after they take the inhaled medication. Now, in general, steroids, mostly PO, can actually stunt growth. The good thing is that we notice that these medications don't affect total growth at the end as an adult. So they might have a stunted growth, but usually the end height of these patients is unaffected. Osteoporosis is something that we can always see with glucocorticoids and we want to watch out for, meaning make sure your patient's taking adequate amounts of vitamin D and calcium. There is some degree of evidence that glucocorticoids can increase your risk for cataracts and glaucoma as we get older. Outside of that, it can also increase our risk for hyperglycemia. So we need to be careful giving these to patients that might have a history of diabetes and making sure we're dosing their insulin or other medications appropriately. Now, one of the most severe things that we always worry about these patients is adrenal suppression. What I mean by that is when you look at the adrenal medulla, if we're releasing a lot of our steroids, which is usually where they come from, that causes the two organs before them to slow down, meaning they really don't need the stimulus anymore. If we are giving the constant stimulus to this patient, well, then our pituitary gland and our hypothalamus might be like, well, you don't need my help anymore, so I'm just going to shut down. Well, what that does is this creates an issue. One, if the patient just stops the medication, that can put them at high risk for adrenal suppression or adrenal crisis, which is why we make sure we taper them off, thus giving the ability of these organs over here to start ramping up their stimulating hormones to start making that adrenal medulla to work on its own without an external stimulus. Outside of that, these medications are only working for prophylaxis. Well, if a patient has increased trauma, fight or flight, which we know we get a lot of hormone release like some of our steroids, this puts them at risk as well. Meaning, if all this is a blunted response, meaning they're only taking the steroids for the asthma, but then maybe they have a trauma and they get hurt, well, that's a huge sympathetic response. And the body says, I need more steroids to help out. I need a lot more to happen. I need more sugar. I need to burn. I need to do stuff. Your body can't do it, which puts these patients at risk for shock or adrenal crisis. So it's always important. Sometimes we'll see these patients with a medical bracelet telling you that, or it's always good to tell the parents and tell the patient that if they're going in for surgery or anything that's increased risk for more stress in the body, to have stress dose steroids ready. A lot of times anesthesia will ask this and be able to give them some stress dose steroids before they go into surgery. But if you're working in the emergency department, it's good to know. If you have a patient that is refractory to treatment of shock, you could be dealing with an adrenal crisis as they has a history of asthma and they're taking chronic steroids. Now, leukotriene receptor antagonists are another medication we see. This is only really used in asthma. And what they do is they help decrease leukotrienes working on the receptors. Well, leukotrienes are released from mast cells, and we know what they do is help smooth muscle contraction, so bronchoconstriction in the airways, and increase permeability, thus making it easier for fluids to get out of the capillaries and into the interstitium or into our bronchi and cause more edema. So if we give these leukotriene receptors like Singulair, we help decrease that effect. Now, some of the side effects is it's really a pretty well-tolerated medication, and we actually really like it. Cromolyn, which is nice, is prophylactically used in asthma. What it is really a mast cell stabilizer. stabilizer. Remember, mast cells release their granules like histamine and all these other things to increase the amount of inflammation. Well, when that happens in the lungs, we see all these symptoms. So if you give cromolyn, we help stabilize those mast cells so they don't pop open and release. Now, one of the more common things we see is beta-2 agonists. Now, what these do is, remember, we have beta-2 receptors in the lungs and also the uterus. Well, in the lungs, we know is when we give this, it's going to help increase bronchodilation, open up those airways. In the uterus, it actually kind of helps slow muscle contractions or that smooth muscle, which can help slow down labor if we have preterm labor. A good example that does both is terbutaline. Terbutaline can be used for an asthma exacerbation and can actually be used for pregnant patients when they're in preterm labor, something common I've seen when I'm doing my practice, and that medication for both. Now, some short-acting beta agonists are albuterol, Xopenex. Now, what these medications are really only used for is PRN only. The reason for that is they really only last a couple hours. So if we're taking them every day, it's kind of pointless. So asthma kids are usually given an inhaler and even COPD patients. So when they're having the short of breath or possibly a small exacerbation at home, they can use a rescue inhaler to help pop open those airways. Now, long-acting beta agonists, meaning the same exact effect a short-acting beta agonist has, working on beta-2 just longer. A good example is salmeterol here. Now, the biggest thing is these are not PRN. Well, it's because they don't really work as fast as our short-acting beta agonists. So if you're really working hard to breathe and you take it, well, those effects might take a while to happen. So you want to stick to more of the short-acting here. Good thing about long-acting is they're going to give you longer-acting effects. Now, let's look at the two diseases because this is very important. COPD is more first line with our long-acting beta agonist. Asthma, not so much. A lot of research has shown that this should not be a first line medication for asthma. What we do see here is if an asthma patient only takes a long-acting beta agonist, they actually increase their risk for mortality or death. Therefore, a lot of our long-acting beta agonists must be combined with a steroid, which is actually pretty amazing because a lot of our long-acting beta agonists are just now becoming with steroids, meaning you get them in the mail or you get the medication prescribed to you, and there we go. Long-acting beta agonists with a steroid. Therefore, we don't even run that risk of only giving a long-acting beta agonist. Good examples are Advair, which is going to be fluticasone and salmeterol, and then Symbicort, which we've all heard commercials on both these guys, which is budesonide and formoterol. So again, we have these two medications in general. Now, I want to make sure you understand that. Long-acting beta agonists by themselves may be okay in COPD, but we tend to see them with steroids as well sometimes. And asthma, never okay. Must be with a steroid. Some side effects that we can see in general, well, beta-2 agonists are obviously found in the lungs and the heart, but in general, these beta-2 agonists are going to ramp up a lot of other things that we've covered before. So tachycardia, tremors, and even some chest pain, which is something you want them to tell you. Because if they have a history of coronary artery disease, you might be overworking that heart. Decreased oxygen supply to the heart and he's demanding more will cause that chest pain, and we might need to move forward. Now, some medication education with these is if your patient's taking multiple puffs, tell them to take the puff and wait a minute before the next one. The reason for that is the one puff will open up those alveoli or those bronchioles, thus, not alveoli, bronchioles, thus giving more space, more room for that next medication to come in. This is also why if they're on a beta agonist and also a steroid, start with the beta agonist because it's going to open up those airway, and then when they inhale their steroid, it's going to have an easier path to go into. So that's just some good education to share with them. Some other medications we can see in anticholinergics. Now, you need to remember a little bit of our cholinergics, which we discussed here. So we have our nicotinic N receptors that don't always go to muscarinic, but in this case, our nicotinic N receptors go to our muscarinic receptors. Muscarinic receptors are usually predominantly parasympathetic receptors. So one of the things that they can do is bronchoconstriction. So if we give an anticholinergic, or to make it easier, just call it an anti-muscarinic receptor, we block that effect of the bronchoconstriction we see here. So good examples are ipratropium or Atrovent and tiotropium or Spiriva. So these are great. Now, the unfortunate thing is they're only approved for COPD. However, as most of you know, we give a lot of these to our asthma patients, especially when they're in exacerbations. Now, we need to be understanding that these anticholinergics have all the side effects of other anticholinergics like atropine, and we need to be educating them. Now, a good thing to remember here is these are often combined with beta-2 agonists. The reason is both of these are causing bronchodilation, but they do it two different ways. Short-acting beta agonists like albuterol is going to do it by working on the beta-2 agonist to cause bronchodilation, whereas my antimuscarinic, like ipratropium or tiotropium, is going to do it by blocking the muscarinic receptors, both causing bronchodilation. Well, beta-2 agonists actually work more in the smaller airways like the bronchioles, and our antimuscarinic more in the larger airways or bronchi. So we are causing bronchodilation two different ways and also in two different areas of the lungs. So you'll see a lot of these called sometimes duonebs, where they have both a beta agonist and an antimuscarinic. Theophylline is a pretty interesting one. We see this more in chronic asthma long term. Well, theophylline, kind of like caffeine, will cause CNS excitation. However, increased levels of adenosine from the theophylline has been proven to cause bronchodilation, which is why a lot of the side effects coming from that same family can cause things like insomnia, restlessness, and even increase your risk for seizures. Now, how do we dose these? Well, for asthma, we kind of call this a stepwise approach, meaning step one, any child that comes in and you think has asthma or you diagnose with asthma, usually is giving a short-acting beta agonist, like albuterol. Therefore, they can use it anytime they might have an exacerbation at home. Next, moving up the step, we usually start an inhaled steroid. Again, this is more first line for our asthma patients and only exacerbations for COPD. The inhaled steroid usually given after the short-acting beta agonist. If you move to step 3, worsening symptoms, you can either go up on the dose or add a long-acting beta agonist. Remember, in asthma, we never give those alone, so we're going to give long-acting beta agonist with our steroid. Now, how do we know how they're doing? I call this sometimes a rule of 2. You're going to ask them, are they waking up at night? Are they using their rescue inhaler a lot more? Are they having issues with exercise or moving around, stuff like that? Well, if they're using their short-acting beta agonist or albuterol twice a week or more, they're having twice a week or more symptoms that are not controlled, then we go to step 2, meaning they're going to get a short-acting beta agonist and they're also going to get an inhaled steroid. Rule of 2s. 2 uses short-acting beta agonist, 2 days a week where they're not feeling well controlled. They're going to step 2, so they're getting 2 medications, short-acting beta agonist and an inhaled steroid. As far as COPD, we use a GOLD report. Oh, and I should add, for asthma, we can use different kind of algorithms to figure this out. But for COPD, we use GOLD report. So it looks at A to D. C and D are obviously the worst, meaning their symptoms are bad, and we look at how bad their exacerbations are. So usually they say, hey, I ended up in the ER because I had pneumonia, I was on a neb treatment, and I was hospitalized. So 2 or more exacerbations automatically puts them down into C and D, which is worsening control of their symptoms. Again, these guys are going to be given, just like asthma, short-acting beta agonists for their acute attacks, and then we're usually going to add on something like a long-acting beta agonist, and then when they come in, we can give them steroids usually for exacerbations. In general, again, making sure these patients are getting their vaccines and staying as healthy as they can. That's all I have for today. Comment with questions, give me a like if you want, and I'll see you next time.